Hello, my name is JessicaEry. The following is my Henry Ford Access Clinic Gestational Diabetes Education Project. This slide is a summation of all the content that will be covered today. It's sort of self-explanatory, so I'll give you a moment to read through. So let's get started. So the first thing we need to look at is the needs of the Access Clinic. Gestational diabetes affects 9.2% of pregnant women in the U.S. The Access Clinic is special in that the majority of the patients are from the Middle East, and a lot of them very newly transplanted to the U.S. from the Middle East. And when we look at the statistics for that, 6 of the top 10 countries in the world for gestational diabetes are in the Middle East, Lebanon included, which is a large portion of our patient population. Complications of gestational diabetes include macrosomia, neonatal hypoglycemia, increased C-section rates. Long-term complications can lead to a mother at an increased risk of type 2 diabetes 5 to 10 years after delivery, or children that are born to a gestational diabetic have been shown to have a more likely chance of having impaired glucose tolerance later in life. Economically, there's also a significant burden placed on the medical community by gestational diabetes. In 2007 alone, there was an increase in medical costs of $636 million attributed just to gestational diabetes. The standard of care is a diabetes self-management education, a medical nutritional therapy, and compliance with the U.S. Department of Health and Human Services physical activities guidelines. We ask ourselves, why does it matter? It matters because the Access Clinic does not currently have a protocol to provide culturally competent education on complications associated with and non-pharmacologic management of gestational diabetes. A little information about our learner. These are patients diagnosed with GDMA1, so not needing pharmacological management. The gender is female. They are 18 to 45 years old. Greater than 98% of these patients are Middle Eastern, primarily Yemenis and Lebanese. Their primary language is Arabic, and their education is equivalent to less than high school. They have a high level of illiteracy and lack understanding of the English language. The goal of this teaching plan is to improve the understanding of complications associated with uncontrolled diabetes, nutritional management strategies, and physical activity recommendations for patients diagnosed with gestational diabetes at the Henry Ford Access Clinic. We then look at the objectives for this project. Objective 1 is that by the end of the first day of instruction, the patient will be able to verbalize 2 complications associated with uncontrolled gestational diabetes. Objective 2 is that by the next prenatal appointment, the patient will be able to identify 2 dietary recommendations for patients diagnosed with gestational diabetes. And finally, the third objective is that by the next prenatal appointment, the patient will be able to verbalize weekly exercise recommendations for patients diagnosed with gestational diabetes. Now to the method of instruction. This teaching plan will be done using a multimedia presentation that is done in PowerPoint and presented on YouTube. It also, a little special caveat, will be done in Arabic, as most of these patients do not understand the English language. The benefits to multimedia presentations is that it engages learners, it creates the ability to easily review information, it increases retention of information, there's an ease of implementation, it addresses the literacy concerns by providing multiple modes of learning, in this case visual and auditory, and it has the ability to be accessed outside the walls of the facility so that continual reinforcement of knowledge can be accomplished. Another small bit of this is also teachback, which is a method of instruction, and it's a kinesthetic learning modality and improves patient retention. We must now look at the literature that supports the methodology chosen. We will review 4 articles. The first article is a level 2 randomized control trial. The population of patients in this trial were Taiwanese people with diabetes mellitus. An experimental study design was used. The experimental group received patient education through interactive multimedia about diabetes for 3 months, while the control group received a routine 3-month patient education. The conclusion was that the use of an interactive multimedia device to intervene in diabetes self-care was effective only in raising the subject's knowledge about the disease. Additionally, the subjects may need more time to implement more effective blood sugar control and self-care activities after receiving instruction. So what does that mean to this teaching project? What it means is that there's evidence that a multimedia approach can increase the knowledge about the disease. The next piece of literature reviewed was a level 5 case report on patients with diabetes with low health literacy. A multidisciplinary group of educators and researchers collaborated to develop a video intervention to help these patients better understand their disease, and then showed that video to the patients. In conclusion, the participants found the intervention to be helpful and informative. For many, the intervention led them to consider behavior changes. For others, the intervention was a prompt for diabetes-related conversations with their physicians. The relevancy of this to the proposed teaching plan is that the video intervention, 1, led patients to want to consider behavior changes, and 2, started the dialogue between patient and provider. The third article, a level 2 randomized control trial done with diabetes patients in the UK, was done by a person trained in adult education, developed a structured educational program on foot care, management, and natural history of diabetes. The program ran concurrently using 3 different methods and 3 practices. The education was provided in one practice by the clinicians, in the second by video and clinicians, and in the third by an adult educator and clinicians. Patient knowledge, hemoglobin A1C, weight, and smoking status were assessed before and after the program. The conclusion was that patients in the practice where video was used scored higher for knowledge than those in the practice that did not use video. That itself is pretty self-explanatory as to how it applies to this teaching program. And finally, the fourth piece of literature reviewed was a level 2 randomized control trial. 190 patients were recruited from clinics at a federally qualified health center and an academic health center. The experiment was that patients were shown the Multimedia Diabetes Education Program, also referred to as MDEP. After being shown it, and before being shown it, there was a measure of diabetes knowledge. The conclusion was an MDEP designed for those with low literacy significantly increased diabetes knowledge across literacy levels. The significance of this to the proposed teaching plan is that using multimedia crosses the barriers that we experience when dealing with patients with low literacy levels. So even though I discussed on each slide a little bit about how the literature review applies to this project, I also have done just a general overview here. The literature review indicated that there is a potential to raise awareness of complications, and that the use of multimedia impacts motivation to create behavioral changes such as diet and exercise that would be needed for this education program. Also, video education has a greater impact on patients' motivation to change than clinicians or educators alone. We find that using multimedia as an educational strategy inspires patients with low health literacy to engage in more conversations with their clinicians regarding complications and management. So the learning theory that I decided to focus on for this project is Edgar Dale's cone of experience theory. It's also called the cone of learning. Dale found that the more actively involved the student, the more successful they were at knowledge retention. He developed the cone of experience theory that integrated multiple modalities of learning in the 1960s. He listed the least effective at the top and the most effective at the bottom. If you look at the graphic, you can see it says after 2 weeks, we tend to remember 10% of what we read, 20% of what we hear, 30% of what we see, 50% of what we see and hear, 70% of what we say, and 90% of what we do. To the left, I've also listed elements in this teaching plan that are directly reflected in Edgar Dale's cone of learning. Hearing words, seeing, watching a video, a movie with a demo of exercise and grocery shopping, which we'll discuss later, discussing with client at future visits, and then having patient keep a diet recall or exercise log as part of the doing the real thing portion of the learning theory. So why does this theory work? This theory works because it engages the audience. It's easy to understand format for clinicians. It implies that a more involved student leads to greater knowledge retention. It has elements of the social theory. It also creates a blanket teaching style that implements several learning modalities to ensure all patients have a chance to learn in a way that works best for them. It also implements teaching techniques that are specific to low literacy, such as avoidance of reading and writing, which is important to this population. This slide is a layout of the actual project and teaching plan. There's 4 categories: content, method of instruction, time allotment, and evaluation. I'll go through each one. So we start with a verbal survey of patient understanding of complications, dietary recommendations, exercise recommendations for GDM. It's 5 minutes long, and there's a pre-test, which I'll show you in the next slide. The reason we went with a verbal survey rather than a written is most of these patients are literate not only in the English language, but also in their own Arabic language. So doing a verbal survey in their language ensures that you'll get accurate results. Once the survey is complete, then you move on to your video presentation. Included in it is an overview of what gestational diabetes is, a discussion of the complications as listed under the needs assessment, and a discussion of non-pharmacological management that were also discussed in the needs assessment, the education plan, the nutritional therapy, and the exercise recommendations. Within the video presentation, we'll also include images of good and bad foods that are culturally relevant and images of recommended exercises. The method of instruction is a video that'll be made accessible through YouTube so that patients can access it on their smartphone or in the clinic supplied tablet. The time allotment is 20 minutes. Once they've completed the video presentation, we again will do a verbal survey of patients' understanding of complications, dietary recommendations, exercise recommendations for gestational diabetes. This actually falls under the teaching method of teach back. It'll be 5 minutes long, and it'll be in the post test, which you'll see in the next slide. Our project doesn't end there, though. One of the reasons that I decided to put it in a format on YouTube that could be accessed by smartphones is that so patients could be able to view this knowledge between appointments. So the provider will encourage the patient to continue viewing between appointments to reinforce knowledge. And we'll also encourage them to access additional resources, which will be a couple more slides. So the method of instruction is the same as before. The video is accessible through YouTube on a smartphone or on a clinic supplied tablet, and is 20 minutes long. At the 2-week follow-up appointment, patients will provide us with a week-long diet recall and exercise log. This serves as a demonstration of their understanding of the knowledge that we gave them and should take about 5 minutes. Based on the results of that, we can ask providers, encourage them to continue to view the video for reinforcement of knowledge or view it as they want throughout their pregnancy. Following is the pre-test, post-test evaluation that was discussed in the previous slide. There are 3 simple questions. It'll be the same questions on the pre and the post-test. These questions are derived directly from the objectives. Question 1, what are 2 complications associated with uncontrolled gestational diabetes? 2, what are 2 dietary recommendations for patients with gestational diabetes? 3, what is the weekly exercise recommendation for patients with gestational diabetes? This slide covers the additional resources. The American Diabetes Association website is an excellent resource. They have a lot of overview information on what gestational diabetes is. The Diabetes and Control website is an excellent source for exercise recommendations. Very specifically talks about exercise in pregnancy related to gestational diabetes, related to the guidelines. And then the website for Medical News Today is a great article on diet related to the Middle Eastern culture. So it uses foods that are generally associated in their diet. The following are my references. And that is the conclusion of my presentation. Thank you so much for listening.